Hello and welcome to Lilia's weekly Wednesday program, bringing themes on trans health more to the forefront for you, our followers. Today's topic is on 3D technology and how it is changing the planning and surgical processes for more predictable results. Today we have two experts, as usual, from two continents. Firstly, we have Professor Devin Coon from the Johns Hopkins University, the Center for Transgender Health. Dr. O'Brien Coon is a plastic and reconstructive surgeon, and he's also the medical director for the Johns Hopkins Center, as I said, for Transgender Health, and he serves as well on the editorial board of the Aesthetic Surgery Journal. Dr. O'Brien Coon has published over 60 peer-reviewed publications and received numerous awards for his work. And he directs also, on the side, a research laboratory at the Translational Tissue Engineering Center, which focuses on scarring and tissue engineering. Very interesting. And on top of all that, he's also developed FDA-approved medical devices, which are now used in surgeries. And he's also a NIH, which is the National Institute of Health, funded researcher whose inventions have led to numerous patents and numerous patents and a venture backup startup. So that's quite a background you have there, Professor O'Brien Coon. And here also I have with us today Dr. Daniel Simon of Facialteam. Professor Daniel Simon and his colleague, co-founder Dr. Luis Capitan, began Facialteam in 2010. It's a multidisciplinary surgical team now with over 50 professionals, all dedicated to gender-affirming facial surgery. His team has performed over 3,000 feminization surgical procedures and has seen over 8,000 patients on 4 continents for consultations. And their R&D, research and development department, is very busy as well, with 19 scientific articles published in leading journals. Which also have earned award-winning awards for the topic of facial feminization surgery. Dr. Simon is co-founder of one of the first facial gender surgery training programs and educational workshops in the field. And under his leadership, Facialteam has implemented 3D software and advanced instrumentology in both planning and surgery. So finally, Dr. Simon and his team are actively raising visibility of transgender non-conforming surgeries and have been selected to form part of the WPATH's surgical work group for the revision of the 8th edition of the Standards of Care, or SOC 8 for short, which is the only international best practices guide in trans health. Welcome, both of you.
Thank you, Lilia.
Thanks.
Welcome, Devin. How are you?
I'm great. It's good to see you, Daniel.
So as a little icebreaker, I like to start always with, how's the weather over there in Baltimore? Are you in Baltimore, Dr. O'Brien Coon?
Yeah, it's hot, very hot. It is officially July in Baltimore, so it's mid-90s Fahrenheit, and it's probably not 90% humidity, but it feels that way.
Last year, yeah, I can feel the heat right now, because last year by this time we were there, right? Exactly by this time.
Yeah, no, and it was 2 years ago you were here in July.
Exactly.
And that was the hot one. Last year was June. That wasn't quite so bad. Sure. But 2 years ago, I remember we had like thunderstorms and humidity, and you really got to see the full full range of ways in which it is not like Marbella.
True. Yeah, it would be nice to tell also the audience about things we have been doing together in the last years, and they're going to be interested, I think.
Absolutely.
Yeah. Do you want to?
Sorry.
Is that further on in the menu, or should we go through?
It's now actually, yeah. I think that it would be good for both of you to give a bit of information first, though, about yourselves and who you are, what you do, a little bit of your background, and then we can talk about what we've been doing together.
Okay, perfect.
Dr.
Okay, so you made a quite introduction already, Lilia. So yeah.
But I didn't talk about why you're working in facial or in gender affirming surgeries in general. Why are you working in gender affirming?
Well, I did differently than Devin, than Dr. Coon. My background is in maxillofacial surgery, so my whole concentration working field right now is the face. Dr. Coon is a plastic surgeon working in other parts of the body as well. So I have been from the beginning only working really with the face, and we have been working in FFS for the last almost 13 years, as Facialteam around 10 years, right, from 2010. And yeah, it has been amazing, the fact that we have been evolving together with the discipline. When we started, it was a discipline that had so small amount of information around regarding techniques, regarding what was the science behind this. So it was a very interesting field to work with, because we have been helping and evolving ourselves in the last 10 years in the techniques of FFS.
Thank you very much. And Dr. Rhino Coon, could you tell us how you got involved with the trans community?
Sure. You know, as Daniel said, you know, my background is as a plastic surgeon. You know, I also have a background in biomedical engineering. And when I was in residency at Hopkins, you know, I had the opportunity to get exposed to gender affirming surgery with somebody who I overlapped in residency with, Rachel Bluebond. And, you know, at that point, I was able to, you know, meet patients and be involved in surgeries. And I was kind of like, you know, that was probably 5 or 6 years ago. And that was what got me interested in it. It was clear that this was an area where, you know, patients were really not getting treated to the same standard as they were in all of the other things we did. And, you know, those experiences made me, you know, decide that this was kind of what I wanted to focus in, because, you know, I really felt that there was an opportunity to make a difference and raise the standard of care that you know, a lot of these patients were receiving here in the U.S.
Absolutely. That sounds like the perfect reason, to be honest. Could you tell us also a little bit about the Johns Hopkins University Center for Transgender Health?
Sure. So, you know, the Center for Transgender Health is, you know, a bit over 3 years old now. It is a Johns Hopkins wide entity, which means it spans both the School of Medicine, where the doctors are, and the hospitals where we do things. It includes all the hospitals. There are 7 hospitals in the Hopkins system beyond the main one that everybody knows. There are ones in Washington, D.C. and some other places. And the real goal of it is to what's called a service line, which means that it's meant to unify everything around the patients. And so part of the service line, which I'm the chief medical director of, is that we have, you know, we have a number of primary care providers who take care of trans patients. We have endocrinologists. We have a whole separate sub-program in pediatrics with pediatric and adolescent physicians that take care of hormone blockers and things like that. And so the goal is really to do the best we can to create a new system where everything is unified, which, you know, people have recognized for a long time in cancer care and things like that, that you really can do a better job if you can bring all the healthcare providers together. You know, that's obviously been a struggle for trans care, but that's really the long-term goal, is to build that kind of integrated model and show how it's done. And then hopefully other places will, you know, eventually gravitate towards something similar. We've had about, you know, a bit over 2,000 patients and in the service line. And we kind of, you know, since a lot of them are getting longitudinal services like primary care and hormones and things, they kind of, you know, are part of, stay part of the service line, you know, whereas, you know, some may just be coming for surgery and then going back home. So there's some heterogeneity in that, but that's the overall mission for the Center for Transgender Health.
Okay, so that sounds a lot like here in Europe, they're called gender identity units or gender identity centers in the public healthcare systems here. But in the case of Johns Hopkins, I assume, is it private or is it are these publicly funded services?
It is private. You know, the U.S. system is, you know, generally, you know, depending on one's point of view, either more free market or more fragmented. You know, it is not really, the incentives are not always there for this kind of unified care. But even, you know, every system has its pros and cons. You know, I think the sort of publicly funded gender units are in many ways, they have advantages that we can learn from. In other ways, you know, they're often underfunded or have resource limitations. And so some of the, you know, if it is, you know, if you want to look at a privately funded gender unit, as it were, then that gives us a little more flexibility. In addition, you know, I think the unique thing about Hopkins is that, you know, they want to have the best clinical care, but the institutional commitment is to a little bit more than that. It's, you know, innovative clinical care, but also research and education. And the fact that those are sort of upfront in the mission means that the institution will support us to do those things. So that's probably another little differential, is that, you know, it's not just, you know, providing the best care that you can, but it's also exporting that and making it, you know, trying to have a bigger impact as much as you can.
You have a lot in common with Facialteam in that respect.
Exactly. That's why we work so well together.
Yes. I just have one more question about the JHP Center for Transgender Health. Is there a waiting list, or what are the approximate waiting times for patients who are in your system?
Yeah, it's a very service dependent thing, because it really, you know, ultimately you're going to go see a type of provider, and it depends on the supply and demand for them. So on one hand, things like primary care, we can get people in to see somebody within, you know, 4 to 6 weeks for a new patient. And, you know, for some things that are a little bit more specialized, like the pediatric patients, where they're all seen by a pediatrician, a pediatric psychiatrist, and a pediatric social worker, those appointments can be, you know, 2 months, or something like that, 3 months. And then when you get into very specialized sort of unique services, like, you know, when I do phalloplasties or redo phalloplasties, then it can be, before the whole COVID thing, you know, 2 years or something like that.
Okay, well, those sound like very reasonable wait times, considering from what I hear from other services in Europe in the public system, there are 2-year, 5-year, or longer wait times, a lot of loopholes to get through, and hopefully that will change in the future. So thank you very much for that background information, Dr. Ryan. Dr. Simon, do you mind giving us a little background information about Facialteam, the vision and values that Facialteam has in trans healthcare?
Yeah, I mean, we talk about this a lot, and of course, we at Facialteam, the vision that we have is it has always been to grow as a team and make as much as possible, the life of transgender women a better life. And if we can do this through surgery, or through information, or through training that we provide to other surgeons that can make better surgeries at their countries, this is all ways of fulfilling the vision. And this is one of the reasons we have been together with Dr. Coon and the Johns Hopkins Transgender Center, because we found a lot of things in common on this wish that Facialteam has to also perform trainings, to publish. We have been publishing together as well. It's amazing how collaborations in publications and in training make the final result not only an addition but a multiplication on the result, on the optimal things that we can obtain. So, as you know, we are a center that works only and exclusively with the face, with specialists working on each anatomical area. For example, I do specifically surgeries on the jaw and the chin. Dr. Capitan is doing specifically surgeries on the forehead. We have Dr. Bezinga doing the nose. So it's a different type of philosophy of work, where we work specifically with one anatomic area, and we have other surgeons that we can count with, like Dr. Coon, for other areas of the body, or in the face when patients are from the States and want to remain in the States. So yeah, collaboration is key, and this is how we have been evolving in the last years.
Thank you very much, Dr. Simon. And that's a useful summary for the viewers who are going to be watching this later. So now, as you both mentioned, Facialteam and the JHU Center for Transgender Health have been working together for a few years now. Can you both give us a little background information on that?
Sure, I can tell you how how we got started. So I was when I first started doing this, I was very comfortable with craniofacial surgery because I had spent 6 or 7 years at shock trauma in Maryland, which is one of probably the 2 biggest trauma centers in the United States, and I had learned it from Paul Manson, who's kind of like the godfather of modern craniofacial trauma surgery. So I was very comfortable with the facial skeleton, but I'm a strong believer that you have to be prepared before you start just doing things. So I felt that I needed to find the right group of people who were doing facial gender procedures in particular at a high level, because you need to have the basic skill set before you even start, but the nuances of how to really get great results from the start, you need to have somebody who's done a lot of them show you the little things. And so that was how I wound up going out to visit them in Marbella for a week. And that was, I think it was love at first sight, right? We hit it off. I was really impressed by their commitment to open sharing of information, and not like trying to be secretive or not share how they did things. They were very open and committed to everybody getting better. And so I think that, and which is obviously at least what we would like to be the case in academic surgery, that commitment to openness and to disseminating new knowledge to the world. So at that point, I think it was clear we kind of had a similar approach to these things. And I think there was mutual agreement by the time I left that week that we wanted to find ways to continue to work together. And then, that was sort of what led me to invite them out the next year to give our grand rounds at Johns Hopkins and do a cadaver teaching session with our residents who, again, have tremendous exposure to craniofacial surgery. But, other than with me, and, there's one me and there's 25 of our residents usually, that's, limited exposure. So at that point, that was an opportunity for them to have some education with like some people who are real experts in this field, which they really enjoyed. And that grand rounds was very well received. So that was the next step. Yeah, that's kind of how we got started.
Yeah. Yes, and this is the amazing thing is the fact that we were able to evolve from this initial collaboration to a professional training program that we did last year, and was a training program for surgeons from different countries. We had surgeons from many countries, right? Then we had Brazil, we have America, we had from Chile,
Hong Kong, Australia,
true.
Yeah, we've had because we've had 2 years. We've had the course for 2 years. We would have had a third year this year, So, you know, we've gotten most of the continents so far.
Yes, true.
You know, year four, maybe we'll get the rest.
Yeah, and it's a very rich environment, right? Because you are talking to people from all over the world. So it's not only a course where we can perform the surgery in cadavers and where we see that we can really train and they can understand the way we do some works, and also we can hear from them what they have been doing. Most of the surgeons that come to us for our training, they are also with some advanced knowledge, and they have some of their own ideas, of their own methods, so everyone learns. And of course, even more important, we network and we learn about the situation of transgender health around the world. So this is really good. And when we met Devin, I'm not overstating. I mean, this was, imagine for us, it's a dream come true to work together with Devin in an institution like Johns Hopkins. We are a team that became well known inside feminization, but we are just a small private center in the south of Spain. So having the opportunity to work together with such a respected institution, with such a nice person that is Devin, because it's not easy to be on the head of a transgender unit at Johns Hopkins and be such a humble and normal person, because we like normal people, you know? And so we were very lucky, as Devin said, and we are very happy with the relationship we have.
Would you like to mention a little bit more about the International Facial Gender Symposium or any of the joint research publications that you've done together?
Yeah, of course. I can tell about the symposium. You can tell the publications.
Sure.
The symposium that it was the first real symposium, officially saying, was last year. We was planned by this year. Of course, it was canceled because of the COVID-19 situation. So we are, at least it gives us time to plan a very strong event for next year, which will maybe even have other subjects. Maybe we are going to involve also some body surgery, right, Devin? So we have more subjects. And we had to cancel as well our training program in Marbella, which also Dr. Coon comes to Marbella every year now. He's one of the faculty here in this course that we do in Marbella, also canceled. But again, it just gives us time to make something even better for next year. And we have had we had used this time to publish more work, and we have been doing some work in collaboration that Dr. Coon can tell.
Yeah, you know, we've had a bunch of projects going which have gone very well. We've had a paper come out in Plastic and Reconstructive Surgery a couple months ago on essentially, you know, planning and approaches for facial gender surgery. We have one that just got accepted that, you know, will probably come out in a couple more months, which is essentially the consensus statement from the Facial Gender Surgery Symposium. And essentially that was the first real multi-center assessment of the status quo in facial gender surgery. And so you had, you know, just a large number of, you know, probably the majority of the world's surgeons who do a lot of this, all in the same room for a day and able to talk about the things that there's disagreement on, the things that we think we all know, and then to put that all together into a consensus statement, which is going to be coming out in, you know, the highest impact plastic surgery journal is a big deal, because that consensus statement we're hoping is going to make a difference for a lot of patients, because you essentially have all of, or a majority of the surgeons who do a lot of this, you know, reviewing literature and saying there's really no way that it's fair to discriminate against facial gender surgery and not treat it the same as genital gender surgery or something like that, which has been the case in many or most, you know, healthcare systems. And so here, you know, we finally have something more than one person saying it. And in addition, reviewing the literature on other things. And, you know, there are other things like facial hair removal that are sort of neglected. So that's, you know, I think that's going to be a big deal, not just for professionals, but also for patients. And, you know, that would not have been possible. It was, you know, really the Facialteam group and Daniel and Fermin, who you know, got that together with me to make that possible. So that would have never happened if we hadn't had this gradual growth in our collaboration, from first the course in Marbella every year, to then the symposium, and then the consensus statement coming out of the symposium. So that, you know, I think is good evidence of, you know, how these collaborations can grow over time and, you know, grow into something much bigger.
We even have sometimes publications, patients are more focused on looking at the before and after results, right? And about what technique you use, but sometimes even they don't have the idea of how important the publications can be for the first, of course, to solidify, to consolidate the discipline, but to make that FFS becomes much more accepted, not only to society, but to medical society and governments and the public health system. We had already a couple of patients that not even had surgery. They didn't have surgery with the Facialteam. They were in America, in different states, and they wrote to us that they have used publications that we have done together to present in front of the judge when they were asking them to cover their treatments in America. Because the publications, they confirm that this is a treatment that is necessary, medically necessary, and not cosmetic. So publications have an impact for the medical field, but also for society, for the patients. It's very important.
Yeah, I can't stress enough what Dr. Simon just said. And for any of you who are listening to this video now, you please look down in the description in the video, and we have links to where you can find the scientific publications, and also to information about the International Facial Gender Symposium. You can visit the Instagram page at International FGS. INTL FGS is the Instagram account, and keep up to date with that, or visit facialgendersymposium.com and stay up to date on the next event, which will happen in 2021 in Baltimore, June 2021. So I just would like to go from here now. Thank you so much for that briefing. Very interesting information for all of our viewers, both patients and professionals. Now, as a segue, I like to go into three things: opinion point, myth busting, and advice. So we'll start with the opinion. And so the first question is gender affirming surgery for everyone who is in transition? What do you think?
Well, I mean, I can talk about the face, and I prefer Dr. Coon to talk about the face as well, but from other parts. Of course, the need of FFS, it's not something mandatory for all the patients. Okay, so of course it's an individualized treatment that we have to evaluate, and we see many patients every month that are on a transition from male to female, and they have no need of FFS, no need of facial surgery. So it's not a fact that if you are transgender woman and you are doing the transition, it's not a fact that you need to have surgery. It's not. It's just we know there are so many other things that are necessary and that can improve without surgery, like the hormone therapy, like facial hair removal, skin treatments, hair transplant, or hair systems. There are many things that can be done even without surgery. For patients where puberty has affected their face strongly through hormones, through testosterone, and where you have bone growth in specific areas that we identify as masculine, for those patients, FFS is advisable if they are bothered by those features, because then we have a lot of patients with masculine features that are not bothered by it and are happy to live with their current face. So FFS is for patients that are bothered by masculine features that are real, that really happen, and that they believe and they can see that if they do the surgery and remove those features, or let's say soften those features, this can improve their quality of life. So there's no rule, it's not mandatory, it's an individualized decision.
Yeah, I think Dr. Simon covered it perfectly. There's it's certainly not for everybody who's transitioning. It's for people who can identify a physical change that they are relatively confident will improve their well-being as part of their transition. And so, you know, we see with the facial surgery, it can be difficult its access is much harder in many countries than to other types of gender surgery. So the rates are going to be lower, but that doesn't mean there aren't more, you know, as many people who want face surgery as bottom surgery or even more, but the rates will certainly be much lower because accessibility to face surgery is far lower. However, with that being said, you know, I have the numbers, you know, for the patients who are on, you know, here for hormone therapy or mental health or primary care. And so we know that many patients do not want surgery, and, you know, it's our job as medical professionals to support that. You know, I think where we can do work in the future is to, you know, do a better job of how to support patients in deciding what's right for them, because that's an area where there isn't a lot of data to help us, you know what to tell people. But you know, clearly it's not the case that everybody is going to need surgery, and anybody who isn't sure about it can just wait. You know, there's no reason for anybody to have surgery immediately. So, you know, I think, you know, it's again, part of our responsibility to help people, you know, in those decisions.
Absolutely. That's something that Facialteam has always made a great emphasis on, is not rushing into things, doing your research and taking your time, making sure that you're confident in your decision, and the team is about supporting patients in that process.
And Lilia, something that happens a lot in the face, it happens many times, as you know, is patients that they want to do something, surgical, they see many things that they want to improve, and what they are not sure still is what do they need. And for example, they are not sure if they should or not touch their nose. They see their forehead is strong, they want to eliminate that excess. So it's very common that we will perform FFS, but leaving some areas without touching so that the patient has time to reevaluate their face. You imagine if you have a patient that needs forehead, nose, chin, jaw, Adam's apple, but the patient is happy with her nose, she's not sure, it's always bad not to do the nose for now, do the other areas, reevaluate your face, and maybe in a couple of years you do something of your nose. And maybe you won't, so then you have saved surgery, you have avoided more surgical trauma. So it's very important that everything is individualized and that no surgeon is never forcing procedures over the patient. On the contrary, that we are just orientating and finding common ground. Okay.
And to me, the easiest example of this is trach shave or thyroid chondroplasty, because patients know when they come in if it bothers them or not. No. It's, you know, the nose, the chin, the forehead, they're more complicated, you know, as far as patients understanding what you can change, as far as the meaning of changing them. But the Adam's apple, you know, you can like the majority of people, you almost don't even have to explain it. You just say, does this bother you enough to have surgery on it? And they can tell you off the top of their head, yes or no. Yeah. And, you know, at least half of my jaw surgery patients don't want the Adam's apple touched because they say it doesn't bother them. And so, well, if it doesn't bother you, there's no way a surgery can make it any better because it wasn't bothering you to begin with. And, you know, that one is the simplest one, but is kind of encapsulates the thing that Daniel's talking about as far as the other features go.
Absolutely. So for the viewers here now, if you'd like to hear a little bit more on the topic of whether or not gender affirming surgery is for everyone, and if you know, if it's really something that everyone in transition has to go through, please check the link below. All the links are here in the description. And there's a nice blog on the John Hopkins Center for Transgender Health on this topic. Now, you already sort of mentioned, both of you mentioned this a little bit already in the opinion point, but the myth-busting point is, can surgery eliminate gender dysphoria?
You start, Devin.
So I think that you have to make it a little bit more specific and say, I would say that surgery can eliminate gender dysphoria related to a specific physical feature or lack thereof. So if the and where it's more complicated is figuring out what percentage of somebody's overall gender dysphoria that addresses. So somebody, can say that, my masculine aspects of my face and being misgendered in public caused me a lot of gender dysphoria. Well, if we do facial gender surgery, we may be able to fix that and that may go away. So if that's the only thing that's causing gender dysphoria for that person, we've eliminated it. However, if it's more complicated, if it's, I have relation issues with my family related to my transition and refusing to accept me, if there are other things in play, then surgery is not going to fix those. And part of what's important when we talk to patients preoperatively is drawing that distinction of saying, we can't know, on the outside what's causing certain feelings that you have. So you have to do some introspection and decide, what percentage of your overall dysphoria is caused by these physical things. And in practice, I think most patients do seem to say that they have much less gender dysphoria, especially for the face. But it's also important to set realistic expectations. And the same thing when I talk to cosmetic surgery patients, you have to separate unhappiness with a feature, which you can fix, versus thinking that, fixing that feature solves everything. And most of our patients are very realistic about this and they understand that, but it's still something you have to discuss with them beforehand so that they go into it with the right mindset, which I think makes a big difference in coming out with being happy about the outcome.
Well, yeah, I mean, this is such a good answer that is difficult to really, you describe it perfectly. Yeah, I think that we know that surgery, it's a tool that can help, but if we are talking specifically about a feature like Devin said, maybe it can eliminate the dysphoria on that area, but it would be too much to say that surgery can eliminate gender dysphoria. We know it's not realistic. It's much more dependable on the patient's story from psychology. There are so many things involved. It's one step. It's one more thing that can help. It's like having someone from your family supporting you during the transition can also make gender dysphoria better, can make your transition better. The same thing as surgery. I don't think one is more important than the other. So it's one of the things that we can do to help, but it's not a magic trick. It's not something that it's easy. It's something that if you choose to do, if you choose to undergo FFS, if you have expectations in place, you'll be happy, and it will improve your quality of life.
Exactly, and we have a publication on the topic of outcomes, satisfaction outcomes. No, Dr. Simon, that may touch on.
Yes, we have a publication that is specifically talking about the perspective. It's a perspective study talking about quality of life after FFS. And it's the publication conclusions is that indeed FFS improves quality of life. It's not specifically talking about eliminating gender dysphoria, but it's talking about quality of life. And it's one of those publications this was a multi-centered publication, many patients answering a lot of questions in many periods of their transition before surgery, when they are with us in the hospital, many months later. So it's one of those studies that I mentioned before that are very useful for the patients in the public system, in medical insurances, in governments, because it's really showing that it's something important. So yeah, we know it improves the quality of life, of course.
Kind of research that both John Hopkins and Facialteam are doing is very important for this reason, that up until now, anecdotally, we've all known that gender affirming surgery has been an important tool, and because of all the testimonials of how it has saved people's lives. People have said it saved my life, not just I'm happier now, but it saved my life. And that's pretty profound, but we haven't been able to back that up really scientifically until now with this with this study.
Exactly, and if no one starts working with this data, and we will not be able to back up something that is obvious, and it is frustrating, right? It must be very frustrating for patients to hear something like yes, FFS is aesthetic, and they hear this maybe from their insurance or from their government. So it is frustrating to us as well. So from this, we have a power that we have to use, which is the power of data. We have patients coming to us. If we are able to organize data, and John Hopkins is very good with this, so we are able to organize all this information together, and we can have then, as you said, a backup, a strong, solid base to show to all these institutions that what the patients feel, as you said, anecdotally, is a reality, and it's what it is all about.
I think it's important to note that you know, that paper on prospective quality of life is not saying that every trans person who, if they got FFS, would have an improvement in quality of life. It's selected patients who were deemed appropriate by a responsible center that had the conversations that Daniel discussed about what can be changed and what can't. I think that if you saw some, you know, one from a place where they just operated on anybody who showed up and asked for surgery, that you would not see that, you know, very predictable improvement in quality of life, because you're not assessing people to make sure they're the right person, to make sure they're gonna have an improvement from the surgery. So, you know, I think it's important to not lose that fact of patients' education and preoperative discussion being, you know, also essential to getting that quality of life improvement afterwards.
Absolutely. We call this the orientation process, and I would advise anybody who asks me. I talk to people all the time that asking me questions on social media, and I always say, you know, if you are talking with somebody who does not insist on you going through this process and having it very clear that the surgery is not going to, like Dr. Simon said, wave a magic wand and solve all of your problems, then think carefully and you know, talk with several professionals and see who feels best. So moving on to our next topic, which is the big advice that we have for our followers here. We need to know one tip, okay? One of the biggest things that you think that patients can do to prepare for their gender affirming surgery.
Well, in my opinion, my biggest tip would be information, because it's what's going to generate the most satisfaction to patients. If patient gets information about what is the surgery, if they research, right? Research about the surgery, research their surgical teams, there's going to be an automatic good combination between patient and surgical team. It's very common that patients that come to us, for example, they are very good matched because they know exactly what is that we do, our philosophy of work. So it's very rare we have a patient coming to us looking for an extreme makeover and looking with artificial aspect and looking like a doll. They just don't come to Facialteam because it's not our philosophy. So if you do your research, it's much easier to get a match with the type of surgery or surgeon that you're looking for. Also, doing research is going to adjust your expectations, which is key in FFS. If expectations are not adjusted, results will be poor. Even if technically the results are very good, if the patients, of course, had an expectation that is this high and the result in her mind was here, even if the result technically is perfect, she will not be satisfied. And fortunately, there's very small amount of complications in FFS when performed well, because it's a very safe anatomical area. It's a very quick surgery. It's not a surgery that takes too many hours on each anatomical area, so there's no high rate of infections. So the biggest complication we see at Facialteam is insatisfaction due to over expectations. So my big tip would be, do your research and adjust your expectations.
Yeah, I think Daniel actually covered what I was going to say, is that sort of related to that. You know, my fellow asked me at some point if I, you know, had a magic 8-ball or something. How did I know beforehand who was going to be happy or not afterwards, which doesn't seem to correlate that well with how good the scan looks. And I told, you know, I said, you know, there's one factor which is bigger than me in determining whether the patient will be happy after the surgery, and that's, did they want to be happy after the surgery? People who come in with a positive attitude tend to be happy after the surgery, and people who come in focusing on super tiny details about what they're unsatisfied with now. You know, my left nostril was 1.5 millimeters smaller than my right nostril. That's not a realistic sense of what our current surgical tools can provide as far as a level of precision. And so those people are setting themselves up to be unhappy afterwards because of those, as Daniel said, not feasible expectations. Now, it's not an easy thing to say, you know, adjust your opinions on this, but I really do encourage people to, you know, it's like the glass half empty versus glass half full thing, right? You can choose post-operatively to focus on the 1 millimeter discrepancy in your nostril that only you can see, or you can choose to focus on the dramatic changes in your face that is what everybody else sees. And so, you know, that ultimately is a decision people have to make for themselves, but I do encourage them.
Very good.
Absolutely. The power of the mind is important here, and Facialteam is always putting a focus on that in all aspects, not just about expectations, but also for healing. You know, just the positive attitude, it helps go through the whole process with a little bit more comfort, I think. And
yeah, there's one thing that I was discussing this the other day with the team when we are now resuming from the COVID situation. And Dr. Coon knows that we have such a beautiful hospital here. I mean, I come to work every day. I cannot believe, because it's I know it's a garden. There's a lot of sun. The hospital, it's like you know, it's like a nice house. It's not a big building. So sometimes I don't know. With the structure we have here and the team that we have, which is so positive, the girls are amazing. You know already Lilia, and you don't know, we have so many patient coordinators. We have therapists, psychologists. And I cannot put still a measure on what is the more important thing when they come to us, because I strongly believe that the technique is improving as always, but the final result of a patient coming out from here normally in tears or giving us a big hug or being very happy, surgery is, I don't think it's even 50% of it. I think that the fact that the patient comes and we show them the respect they deserve and we give them the care they need, and they see that we are so positive about the surgery, because we call it a happy surgery, right? It's you make a choice, you save, you make a trip, sometimes with your loved ones, and you come to here. I think what Devin said is exactly true. If you try to come positive, but we will put, of course, our positivity as well. And we see results. We see that when we try to improve the situation and give a lot of care, patients will always have results immediately that are better than if they would just have a technical thing on their face and go away. You know, it's not about that anymore.
Absolutely. So we've been going now for just over an hour. It's going a little slower than I had anticipated, because you guys have so many good things to say. So let's get technical.
Yes.
Right? We're talking about expectations, and Devin mentioned, I hope you don't mind if I call you Devin.
No, sure.
It mentioned, you know, talking about the millimeters and the precision and the importance of that. So could we go into now talking about 3D imaging now? There are a lot of people talking about the use of 3D technologies in surgical preparation and planning. Can you tell us, both of you, a little bit about the diagnostics that come into play, how it's applied in surgery, the software, etc.? Would you like to start, Dr. Simon?
I can start. The 3D technology is a revolution for the patients that are watching to have an idea. Me or Devin, we have been operating not long ago only with X-rays. Okay, and a CT scan is not something so new, but the quality of the scans is something very new. And at some point, I think it was even 2012 or 13, is when we were able to start working only with CT scans and leave the X-rays aside. Okay, and then the CT scan was giving us these amazing images, like I can show you here, which is the 3D results. So a patient nowadays will scan their skull, and these are the images we can get. It's amazing images. So it helps us, this 3D technology, not only to plan the surgery, but to make the patient understand exactly what's going on. So you're taking a patient that has adjusted the expectations, they're coming with a positive mind, and over this, you put a lot of right information so they see what's happening. When you see what's happening, it becomes less cloudy. And when things are less cloudy, patients are understand much more what's going on and like the results and appreciate the result much more. So regarding diagnostics, 3D imaging for us, of course, is amazing. And of course, we can do slides, we can move the head, we can see what's going on inside, the sinuses, the nose. It's a lot of things that we can do through talking about diagnostics. But I let Devin tell about his point of view in this part of diagnostics as well.
No, I agree. I mean, there's still a broad variety of practices. You know, there's still people who only use X-rays.
Yeah.
But I think, you know, to me, it's hard to justify that because the technology has become more accessible. And, you know, as Daniel said, it makes a real difference as far as precision and getting the kind of results you want. I mean, patient, you know, traditionally in craniofacial surgery, you know, if you have a syndromic kid or you have somebody who's half their face has been blown up, there's a certain amount of wiggle room as far as it was really bad to begin with, and you know, you're trying to make it better, but you know, perfect may not be achievable. This is different. This is closer to aesthetic surgery, and patient expectations are closer to aesthetic surgery. People do expect something close to perfection. And the only way you can get that, particularly with regards to things like symmetry between sides of the face, is by using technology. Nobody's eyes are good enough to tell a 1 millimeter difference between, you know, some small part of the mandible. And so I think that, you know, reflective in this particular area of facial surgery, there's a reason why these technologies have special value.
Yeah, and then we have this is only diagnostics, and imagine how this make a difference on the information to the surgeons, information to the patients, and then we start with the much more exciting things. So we skip from diagnostics, and now not only we see what is going on with the skull, but we now can make plannings on this CT scan and take this planning and bring it inside the operating room. We have been working strongly in these plannings with the lower jaw, and I will show you what we have been doing. Dr. Coon has also been working with forehead, right? And there's a lot of digital planning that we want to evolve. We are now working also with planning for the nose. We want to work with planning for forehead reconstructions, complex ones, as Devin knows, since FFS become more and more common, more accepted and more reachable for patients and surgeons. We are seeing a rise of cases of, let's say, not optimal results in FFS. For those patients, a good planning, a 3D planning, it's a must. It's very important because sometimes we have bone defects from previous surgeries that we have to reconstruct. And this 3D planning helps a lot. So, Devin, if you want to talk a bit about your view on the 3D planning, how can we translate this into surgery? And then I can talk a bit about the jaw as well.
Yeah, you know, I think like you said, particularly in revision cases, you almost need this planning because it's just too hard to deal with otherwise. You know, I think each particular surgery has its own value proposition for where the technology helps. You know, I think that it also helps a lot with educating our trainees so that they can understand the thought process And so for, I think for foreheads, it's helpful to sort of design the optimal bone flap that you think is going to work, with the ability to kind of hit Control Z and undo where you move the bone to and try something else and see if you like it better, which is not something obviously that you can do in the real world. In the jaw, you know, I think you know, cutting guides and for my genioplasty operations, I'll usually do custom titanium 3D printed plates. And so, you know, I think there are different ways you can do it. Like this is my case tomorrow. You know, I can just show it real quick. So this is a one with a cutting guide, and then a
Dr. Coon, maybe do you want to share screen it?
there we go.
Oh, here we go.
Oh yeah, that's working. Yep.
And so you can see the you know, it's a custom titanium plate for a 3-piece genioplasty, which is kind of an unstable movement, and that allows me to very precisely know where the bone pieces go to like less than a millimeter, which would be otherwise hard to do because there's 2 free-floating pieces of bone. And then I can also design the plate so that it provides soft tissue support in the places where I want it and not in the places where I don't want it. So I can actually use it to augment the sort of the alveolus of the mandible as well, which is not something you can really do you know, unless you have the ability to kind of make any plate you can imagine in your head. Yeah. So I think that's, you know, that's an extension of what is being done in kind of craniofacial or in orthognathic surgery. And, you know, a lot of the new innovations are things we find in other areas and realize they have value in facial gender surgery.
Yeah, we have been evolving specifically. First, we have been focusing on the jaw and chin, because the jaw and chin surgery, for the patients that don't know, it's one of the procedures that we have more difficulty of visualization during the procedure. When we are doing a forehead surgery, we have normally a coronal approach, an incision that we expose and see directly the whole forehead at the same time. When we're operating the jaw, we have to work from inside the mouth. So this is rule number 1. So it means we work with small incisions, a very small amount of light coming in, and we will never see the whole jaw at the same time. We have 2 sides and the incisions are separated. We have 1 incision here, 1 here, and 1 here. So 3D planning became really necessary because you, as Devin said, there's no surgeon that is able to control with their eyes or hand 1 or 0.5 millimeter on both sides and give full symmetry. So the planning became very important. So what we do is that we are now, after we have the scan of a patient, for example, like this one, or this one, so we will evaluate the jaw. We will have the patient in front of us, of course, at the same time. And we are going to start making decisions, measurements and decisions. Okay, we are going to work on the angle, we are going to work on the chin, we are going to make the jaw smaller, or we are going to make the chin more narrow. Then after we make these decisions, we are going to start a planning where we really draw over the scan, the bone that we want to remove. And this can be transferred to a real surgical planning software. It's like a software that looks more or less like this. So then the same skull is now in the software, and we are able to design the amount of bone we want to remove. It's the purple area, like here. And then what happens next, which is very interesting, very nice, it's that the software 3D prints the purple area. So it 3D prints the area we want to remove. And this is how we generated a real cutting guide that we use in surgery that looks like this. So you have the jaw, and you have a cutting guide that was generated. So in the surgery, we are able to fit this cutting guide from inside the mouth. We cannot put it like this. We have to cut it in the middle in the surgery. So we have 2 pieces. We fit it in the jaw, and then we will have only to follow with our instruments, follow the guide, and do the cut that we need. So what does it mean? It means many things, but mainly it means that we can work with smaller incisions inside the mouth. It means that the precision we are going to obtain is going to be dramatic. We are now finishing a strong study about the precision that the cutting guides make to us. And it's being done, it's a work done by engineers that work with airplanes, and they really measure millimeters, and they're measuring for us what is the precision. And it's less than 1 millimeter error margin. So it's amazingly precise. And I think one of the most important features is that by having cutting guides technology like this, you are able to transfer knowledge to surgeons that are less experienced, because now they can go to surgery having a cutting guide, and this will avoid them to do asymmetric cuts or leave bone steps or do surgeries that were not even enough. So having cutting guides is going to decrease the learning curve from many surgeons around the world. So 3D technology, it's awesome for the surgeons, for the patients, and for future surgeons as well.
Absolutely. So Dr. Simon and Dr. Devin, do you have any other comments in regards to the 3D technology, the planning process based on 3D technology that we should comment here before we move on to the next topic? Well, there's no more topics really.
Well, you have something, Devin?
I mean, I think just that, you know, I think this is, you know, it may not be the standard yet, but I do think that this will be the standard in the future. Like I said, patient expectations are high, and they're higher than what sort of a freehand human can achieve without some kind of technical assistance. So, you know, combining those two facts, you know, it's hard to see how this kind of won't become the standard. I do think that Daniel raises a great point in that and especially for the jaw, because the visualization is so poor, it's almost not possible. I would say it is impossible to get, you know, with the forehead, you know, you could probably, if you were really good, get the same result that you planned freehand. But with the jaw, I don't think it's possible to get the same result that you plan based on the preoperative imaging. And so there are a number of different ways, you know, that you can do that as far as, you know, getting that accuracy. I can try, I brought it up on my computer. Should we try the screen share? I can maybe get a better view than
you should be able to screen share without a problem.
Okay, there we go. So can you see?
Yep.
Yes.
Okay, so this is, you know, like this is what I was trying to show earlier, but for the jaw, you know, you can kind of plan out and make your cutting guides just like the Facialteam guys have done. And then, you know, this is to get the custom plate and the genioplasty movement that you want, is, you know, and then you can use the plate itself to shape the soft tissue you want, so that you don't have a genioplasty step off and, you know, pack it with bone graft or whatever. So, you know, that's the kind of power that you can get from this stuff, and there are different ways that different centers can do it. You know, I think the Facialteam guys have done a great job of innovating a lot of stuff in-house. You know, a lot of the guides that they've come up with and the 3D printing and things they've you know, worked on themselves and managed to come up with new things. And then there, you know, are you know, the same. I don't think, you know, most places in the world are probably not going to have the resources to do that, but there are companies, you know, just for like for orthognathic surgery, which is certainly a more widely accessible operation. There are companies out there that specialize in supporting surgeons with this technology. So I would imagine that, you know, as this progresses, those companies will be better at supporting FFS, and, you know, at that point it will become the standard, because you know, I think the papers, you know, that they're working on and others are working on will show the improvement, but I think, you know, those of us who use it for a reason. You know, we kind of know that it's more accurate.
there's something important about 3D planning as well, right, Devin? That as soon as you find a way of planning your surgery so precisely, for example, with cutting guides like the ones for the jaw, you have to evolve in other areas as well, because after you have that guide placed, you say, okay, this is amazing, I know exactly where to cut, but this cannot be done with a regular saw, for example. So then you have to go a step further, and you have to work with more technology. You have to find options. So for example, on the jaw, we have to work with a combination that is very positive for the patient. We have to work with a cutting guide and ultrasonic technology, which doesn't damage soft tissues, but cuts through the bone. So one technology brings the other up. It will happen the same, for example, in the nose. We are now working strongly with the development of a cutting guide for the nose. We are already not doing any more hammer technique, so it's very rare. We almost do all our cuts with ultrasonic technology, but now we want to go a step further and use cutting guides as well, which will only be possible if we use ultrasonic technology. So it's amazing how when you evolve, one thing can bring the other up. So yeah, there's so many things we will do with 3D that we are really excited.
It's the future.
It's the future.
We'll have to wait and see. So both of you, I would like to know if you could share with our viewers a takeaway message. Given that we've talked about quite a few things here today, we've done a little myth busting about gender dysphoria, and we've talked about expectations. Is there just one brief message you'd like to leave with our viewers today?
Dr. Coon?
I mean, I think it's probably just that, you know, out of all the things we've talked about, the common message is probably that the future is looking bright. You know, I think accessibility to FFS is about to go through a huge surge. We're starting to learn more about what works and what doesn't for surgical techniques as multi-center collaborations get going and we have data. And, you know, I think the treatment of FFS as a second tier by healthcare systems is finally ending. And with all these new technologies, the results are going to continue to get better. So there are a lot of things that are coming together to hopefully put us towards a sort of a golden age for this type of surgery. So I think to patients out there who are thinking about this, you know, there's a lot of reason for optimism as we, you know, look on the next couple of years.
I fully agree with your message, and I just confirmed this, that we have the subject today mainly was 3D technology, but we talk about so many things because every time we meet, we have so many interesting things that we can discuss. And my message is exactly this. It's a message of optimism, a message that you can see that not only we are here talking about technology, but we are talking about this from different continents and collaborating, and even talking about the multicentric studies we do together with other centers from other countries. So patients, they should know, and they can know that there is a network working strongly, trying to develop more this discipline. We are trying to develop not only it scientifically, but also we are developing new techniques. We are working with other centers, and we are working inside to improve the technology so that surgery is safer, surgery is quicker, recovery is better. And mainly, as Dr. Coon said, you will for sure see in the next years a surge in this type of treatment. And we really hope to be involved in this surge in helping centers, professionals, and patients so they can enjoy these new techniques. They can really use this knowledge that we have developed in the last years together, so they can have a very good FFS, safe FFS with the right procedures decided. So a good diagnostic, we said in the beginning. So it's a message of hope, and of course a message of openness. We are here completely open, as I know Dr. Coon is as well. It's very easy to get in touch with us. And if you need anything, Lilia can answer many questions. We can make video calls with the patients. We never charge for any kind of this type of calls. We like to give a good orientation so the patient starts their process and have a guide map on their minds about their face at least. Okay. So yeah, message of hope, and a lot of big thank you for the people who have been watching us here today.
Well, there really isn't anybody here today except for Dr. Capitan and Melissa, but yes, that will go into the edited version.
For me, it's enough.
That's true.
Oh, Luis, he's hiding. Where are you at, Luis? He hasn't been here all the time, has he?
No, he came in and
Okay,
recently, just in the last few minutes. Yeah. He didn't realize that this wasn't going to be live, so yes, I gave him the link while we were talking just a few minutes ago. So to get back on track here, thank you so much, both of you. Everybody, please show us your claps in the comments. And remember to check the John Hopkins University Center for Transgender Health's website. The link is in the description below. Also, remember, we have the links here to sign up for any reminders for our live events. Even though this is recorded, most of our events are live on a weekly basis. So please do check our social media to keep updated, sign up for our newsletter. And remember, we also have a 3,000 strong Facebook private group where you can share your experiences and ask questions from other people who are also considering or have already been through the experience of facial feminization. So thank you very much, Dr. Devin O'Brien Coon from Johns Hopkins University's Center for Transgender Health. It's been a pleasure.
Well, thank you so much for having me on. It's been great to see you and Daniel, and at least type from Luis again, and hopefully we'll be seeing each other again in person soon.
And thank you so much also to my boss, Dr. Simon here, founder of Facialteam, co-founder with Dr. Luis Capitan.
Thank you so much, Lilia. As we told you many times, you are doing amazing work. You appeared as a very nice live presenter during the coronavirus crisis. You remain like that because you are great. We have fun in these interviews and in these lives. So we will keep doing it. Thank you so much.
It's my pleasure. And as Dr. Simon said, we started doing these events when the pandemic began, and we will continue to do them because we've realized this is a way for us to reach out and get important information to you, our followers, because your healthcare matters. So thank you everybody for coming. Please let us know your questions in the comments, and we'll be back next week. Bye-bye.
Bye.
Bye.